my one slide? Are you seeing one slide right now?
One slide and the next. Now, yes.
There we
Okay,
go.
now you're seeing one slide.
Yeah.
Oh, okay. Wonderful, wonderful. You're seeing one slide. Awesome. All right. So what I'm trying to say is by attending this webinar here today, you are going to be the pioneer of regenerative medicine for sexual health. And let's go ahead and start. All right, let's see. I don't know why I can't move it. Okay, here we go. So overview today, my talk is that why sexual health is good health. And we're going to go over the female anatomy and the sexual response. And then we're going to go over the biologic for female sexual health and how sexual wellness and sexual health is really a multimodality approach. So I want to start with that sexual health is just not only an organ. It is also, let me go back. It is also a component with physical health as well as mental health. And it's an interplay between the three. And that I'll stress this again, but the most important organ for sexual health is actually the brain, not the sexual organ itself. And studies have, this study in 2021 showed there are many benefits of good sexual health, good sexual energy that translate just beyond the bedroom. Sexual health, good sexual function in the bedroom, it can decrease stress, decrease depression, decrease pain, decrease heart disease, and decrease the incidence of cancer. Also, twice weekly relation decrease the incidence of MI by 50%. And that intercourse is actually moderate exercise, burn about 100 calories. It also increased longevity and increased sense of well-being, increased immune function, increased joy, increased bladder function, increased self-esteem and happiness, improved sleep. And sex is really considered moderate exercise. I'm not making this up. This is in this study, but this is why we talk about this, because sexual dysfunction is the only disease that affects the couple. If you are in a relationship, it affects two people, not just one. And so I'm going to be talking about female sexuality. And Tina covered a little bit the prevalence of female sexual dysfunction is between 38 to 52% worldwide. And in the US, and this is important, age between 18 and 59 is 44%. So sexual dysfunction is not only for older women or postmenopausal women, it's also affecting women they're 18 to 59 years old, 44%. That is a lot. However, there's age-related prevalence pattern that if women is between 46 to 50 years old, it's about 23%, and that 51 to 55 is 45%. But when you're in postmenopausal or women that does not have a period for 1 year, it's up to 70 to 75% that experience some form of sexual dysfunction. And we'll go over what is sexual dysfunction. Well, sexual dysfunction for women it's a little bit more complicated than men. For men, it's like, is it ED or is it not, right? For women, you have about 5 categories, right? There's low sexual desire, which is the most common, affecting 22 to 38% of women. And then there's arousal disorder, which affect between 10 to 35%. And then orgasmic dysfunction, which affect about 10 to 45%. And lubrication difficulty, which affect between 11 to 21%. And then you have the sexual pain or dyspareunia affecting 7 to 15%. But guess what? These condition does not go away with aging. So if a woman has this when she is 18 or has it when she is 30, it does not get better with aging. So this is the only thing that for women, it does not get better. But a woman that has menopause symptoms such as like hot flashes, night sweat, and all that, it gets better. But the sexual difficulty does not get better. And so I want to stress that there is clinical distress versus dysfunction. When somebody had dysfunction, but is it distressing them in their life? Is it distressing them in their relationship and their quality of life? So we talk about any sexual problem for women is between 44%, right? But distress associated with the dysfunction, that it means that it bothers them, only about 10 to 12% says that they are bothered by it. And this is the most important part that I find very distressing, and that the women, only 10% really raise this issue up with their healthcare provider. So that means that if they're having problem, if 44% of women having problem, and only 10% of the 44%, which is really 90%, are now suffering in silence and suffering alone, or they may not even know that this is a condition that can be treated, right? So that is a very sad data, I think. And Asina had talked about the sexual dysfunction is multifactorial. It's a physiology, psychology, social cultural issues, and interpersonal issues. That's why it makes it fascinating. And I wanted to kind of stress to mention that there are risk factors that you should know as a provider in looking when you're looking at your patient, and these health conditions are risk factors. Uncontrolled hypertension are more women with uncontrolled hypertension are more at risk for sexual dysfunction than controlled hypertension, and 90% of women with a sexual dysfunction have essential hypertension. So that's interesting, right? And then other risk factors that put women at sexual dysfunction: heart disease, diabetes, rheumatoid arthritis, chronic pain, cancer, and those undergoing cancer treatment, and gynecologic factors such as history of abortion, multiple pregnancies, and genital mutilation. And then lifestyle and conditions such as menopause, certain medications such as SSRI, tricyclic antidepressant, non selective RI, beta blockers, diuretics, and ACE inhibitors. There's not to mention other lifestyle. It's like women that are more sedentary or more at risk, smokers, poor sleep, alcohol consumption, and also drug addiction. So let's just kind of talk about why are we talking about this, because luckily there is a standardized questionnaire that is called the Female Sexual Function Index. It's a validated questionnaire that Rosen came out with, and this is like, I believe it was 2000. That's right, 2000. It's a validated questionnaire to assess different domain of sexual function that I had put out earlier: desire, arousal, lubrication, orgasm, satisfaction, and pain. And it's a long questionnaire, but I will give you access to it at the end if you give me your information, and I'll give you this questionnaire. So it's 19 questions, and if you score of 26 or less, then you are diagnosed with sexual dysfunction. And but I advise that you ask the question yourself and interpret the answer instead of having the patient do it the question themselves. So there is a test that you can measure with a patient, and then you can also give them a periodic this questionnaire to see how they improve with treatment. So let's go talk about female sexual physiology, talk about anatomy, nerve, vascular, and hormone. The last time, if I don't know, you're like me, unless you're a gynecologist, urologist, last time I looked at female physiology and anatomy was probably in med school, because I'm a pain management. And so getting into this field, I really have to kind of really dive into this pretty deep. Let's talk about the external female anatomy, the glands. So the clitoris is really a small version of the penis. The clitoris has 8,000 nerve endings, twice as many as the penis. And then the clitoris also has the corpus cavernosum, which fork out, and I'll show you that picture. And then there's also the vestibular bulb and the labia majora and labia minora. So this is a picture of the clitoris. This is the gland, which is similar to the glands of the penis. This is the corpus cavernosum. This is also the clitoris, which is analogy to corpus cavernosum of the penis here. So 90% of the clitoris is actually hidden. What you see here externally, it's only the head of the clitoris, the glands, but the 90% of it is actually hidden behind the labia minora, which is what you see here. This is the corpus cavernosum. It fork out like a wishbone, and this is the bulb of the vestibule, also part of the clitoris, which is analogy to the bulb of the penis right here. So this is all behind the labia minora, and this the corpus cavernosum to here is it's a total of 4 inches. So it's not just the tiny little bulb that you see. And so here's the external, and here's just a picture of the labia minora removed. So this is the bulb of the vestibule I'm talking about, the corpus cavernosum here. And this is actually an erogenous zone for most female here, in addition to the clitoris. But however, the entire organ is the clitoris. And let's look at the anatomy of the female sexual organ. There's a vagina, and it is the muscle canal that is 7 to 10 centimeter in length. And then you have the vaginal wall, which produces lubrication. And then you have the vaginal expansion that happens in the inner 2/3, which lengthen and expand during arousal, which is called the tenting effect during arousal. And then you have the uterus and the cervix, which during arousal, the uterus elevate and retract to lengthen the vaginal canal. And there's a vascular response, right? And it's a vascular response of the vagina. You have increased blood flow changes. You have the clitoral blood flow, which increases 4 to 11 times more than baseline, which is a little bit less than the penis. The penis actually increases blood flow by 400% when it is erect. And then you have the vaginal blood flow, which increases threefold. And then you have increased oxygen tension, which increases the vaginal wall oxygen by about 4 to 8 times. Now, arousal for female response is the vasocongestion process. Then you have arterial dilation, which then relaxes the smooth muscle, which then allows more increased blood flow. And then you also have venous compression, of when the labia when the labia is engorged. I mean the vagina is engorged as well. The whole labia is engorged. You also have reduced outflow, which then compresses the veins. Then you also have tissue swelling as well, which result in clitoral erection and labia engorgement, very similar to the male response. So increased blood flow, the veins get compressed, but instead of getting full erection, the clitoris get erection, and there's labia engorgement. Let's talk about lubrication. So there are lubricants is secreted by the vagina, the Bartholin glands, the skin glands, and the cervix. So what is the Bartholin gland? The Bartholin glands are right here, which is right just underneath the introitus. And then here's the urethra, and the skin glands are the periurethral glands, which are very important for lubrication and in prevention of UTI. And there's also the neurological component of female anatomy. The brain region involved in sexual response is the hypothalamus, the limbic system, the thalamus, and the cerebellum. Now, men have this also, no difference. And there's the neurotransmitter system, which involves dopamine, which is released during arousal and orgasm, which is associated with pleasure and motivation. And then there's oxytocin, which is released during stimulation and orgasm, which facilitate bonding. And then nitric oxide, which is critical for smooth muscle relaxation and blood flow. And then you have vasoactive intestinal peptide, which enhances vaginal blood flow and lubrication. Then let's not forget the peripheral nervous system, which is the spinal cord. You have the sacral segment, and then you have the pudendal nerve, which is the primary afferent pathway, by the way. And then you also have the sacral segment, which mediate genital arousal reflexes, and then the pelvic nerve, which is the autonomic nervous system. Okay, so autonomic nervous system is parasympathetic, promote vasodilatation and lubrication. So you have to be in the parasympathetic mode in order for you to get ready get ready for the sexual arousal response. And then you're in the sympathetic nervous system for modular arousal and orgasm, but mainly more in orgasm. So it's a switch between, you start with parasympathetic first, and then you switch to sympathetic nervous system. And let's not forget the pelvic floor muscle as well, because they're very, very important, but oftentimes very much neglected. The pelvic floor muscles, such as the pubal coccygeus, is involved in orgasm. The bulbospongiosis is surrounds the vaginal opening, contract during climax. The ischial cavernosus maintain clitoral erection and contribute to orgasmic contraction. And then you have the pubal rectalis, which is help in pelvic floor support during orgasm. Let's look at these muscles. So this is the ischial cavernosus that I talked about that help with the clitoral erection, and then the bulbospongiosis right here, which surround the labia as well, and the pubal muscle. It's actually around right here, which is not shown in this picture. So I'll skim over this. This has already been mentioned before. So we are here because we want to find out how can regenerative medicine with PRP help with female sexual dysfunction, right? So platelets come from megakaryocytes. It has alpha granules, and PRP activates cellular response for angiogenesis, new cell proliferation, and migration of stem cells to the area and production of the extracellular matrix. So a study by Everett showed that, hey, this was done in 2023, that you need a minimum effective dose of 3.5 billion platelets per injection for soft tissue pathology. And the sexual organ is soft tissue pathology. So that means you need at least about 60 cc of whole blood, and you need to have platelet recovery at least 80 to 90%. And the MSI PRP system had consistently demonstrated a platelet recovery of at least 90% most of the time. So I'll skim through this, but essentially, this is the platelet-rich plasma layer right here, which is the white buffy layer, which then releases all of these growth factors, which really is produce more blood vessels and cell growth, right? All right, so we know how PRP works. But why are we talking about this for the female sexual system? Well, let's talk about the G spot. The G spot was first described by a German psychologist. And this is actually should be 1950. It's an erogenous zone found in the anterior wall near the urethra as well, and it's surrounded by erectile tissue like the corpus cavernosa. It's probably surrounded by the bulb of the vestibule, and is located halfway between the pubic bone and the cervix, 2 to 5 centimeter into the vagina, and is part of the clitoral vaginal network. So this is sagittal section. This is the urethra, and this is the superior vaginal wall. Here's a vagina, and here is somewhere between here is the G spot. But the G spot, interestingly, is surrounded by urethral glands. All right, and it's also surrounded very near the skein duct, which I have right here. And so a schematic of the G spot right here. And then also this associated with the skein gland, which is the female prostate organ, and the Bartholin glands, which are down in the vaginal orifice here, which help with producing lubrication. So I'll skip over this, but what this slide is saying is that PRP is safe to be injected in the sexual organ, male and female, because it does no reports of granuloma, infection, or any serious side effects, and that PRP flows into the tissue as a non-viscous liquid, and it is safe. And these are multiple studies that I have listed under the reference that demonstrated PRP help in the sexual response area because of the growth factors in the cytokine. It stimulates neogenesis, fibroblasts, and glandular proliferation when the skin glands, new neuronal growth, and also improve physiologic response and also nerve sensitivity as well, and improve arousal and orgasm. So it's studied by Nito, PRP for intimate female treatment, where he did a prospective study looking at 68 women, age 32 to 97. And they have lack of lubrication and have female sexual dysfunction, such libido, arousal, and dyspareunia. He he injected PRP uh, um, 2 months apart, HCC of whole blood, which is very small, and then ends up with 4 PRP at 4 cc activated with calcium chloride. He injects into the G spot and 0.5 cc's in the skin glands each, and 1 cc in the clitoral area. What he found, interestingly, was that 95% were very satisfied and 90% improved stress incontinent, and that only 6% did not improve, but that was overactive bladder. So this was what's called like the O shot that you hear about. And then Runnels did a study in 2014 that looked at 11 patients with female orgasmic disorder and hypoactive sexual arousal disorder. And he followed along with the female sexual function, and he injected 4 mLs of PRP into the G spot and 1 cc into the clitoris, saw 71 improvement, and that is what is called the O shot. And PRP in this study here in the 2024 systematic review found that PRP reduces vaginal dryness, burning, and dyspareunia while improving tissue elasticity, which is big because this is the number one symptom that women suffer with during menopause. And this study here that I listed here shows that it can be helpful for vaginal atrophy, particularly in breast cancer patients who cannot have hormonal therapy. And they did this with another kit. Dawood in 2018 did a review of the clinical uses of PRP and from 2000 to 2017, and concluded that PRP is currently considered a new therapeutic modality for disorders that are refractory conventional treatment. So I want to go over this study that shows that PRP is effective for stress urinary incontinence for women, especially when it's injected into the anterior vaginal wall, which is the area that I just showed you right there in that picture between the urethra and the anterior vaginal lining. And this is improved for mild to moderate stress incontinence. And also, but there's studies that I've also put in the slides as well. PRP is also good for lichen sclerosis. We mentioned about vulvovaginal atrophy, dyspareunia, pelvic organ prolapse, endometrial and follicular growth. There has been PRP injection into the endometrium and the ovaries, as well as only been one patient that has had that. Also, PRP. There was a study by Prodromidu that showed that PRP helps with mesh pain. I wanted to mention this, that sometimes it's just not PRP. Sometimes you can do microautogenous fat as well. The study by Lai shows that injection of MFAT improve sexual dysfunction in 20 women, and he demonstrated that with histological evidence of increased collagen production and neovascularization and estrogen receptor expression, and reduced neuropathic pain. So I want to emphasize that there's specialized application too, because for breast cancer survivor either undergoing chemotherapy or in remission that can have hormone, PRP for these group of women is a life-changing treatment modality. And so I want to show you my protocol for how I treat urinary stress incontinence or in condition of decreased lubrication and increased sensation in the for the female. So I will get out 120 cc's of whole blood and with the M-Site kit, and I would spin it down to about 6 or 7 ml of PRP, leukocyte rich. I want it to be orangey. I don't want it just to be amber. I do want some leukocyte in there. But before I do the injection, we would numb up the clitoris and the G spot and anterior vaginal, superior anterior vaginal wall with lidocaine and 7% benzocaine called BLT cream, and also around the periurethral area where all the skin glands are. And then I would do the clitoris block with 1% lidocaine and about 0.5 cc ml. And the PRP is then activated with 10% calcium chloride at 5% volume. So if I was going to inject in 7 cc's of PRP, then I would mix it up with like 0.4 ml calcium chloride. And then I would inject around 3 to 4 mLs at the G spot, and I inject 0.5 ml lateral to each skin gland, right? So a total 1 ml, and then 1 or 2 mLs in the glands of the clitoris. And then if a female has dyspareunia, I would inject the PRP in the area of pain, either the labia minora or labia majora. These are all the references I mentioned earlier. And I want to, and not the last slide yet, but I also want to stress that if you're a provider and you're treating women and you're seeing women, know that no woman should live with painful intercourse of a physical cause or dyspareunia. This treatment can it can be treated within days. And it doesn't even have to be with PRP. Yes, it goes quickly. You use PRP to inject in the area of pain, but you can even prescribe just topical hormone, such as estrogen, that will be life-changing for her. She will not have painful intercourse again. Women describe to me that every time they have sexual activity, it feels like sandpaper. It feels like burning. No women should live with that. So if you are treating women, just know there is a treatment for her. She did not have to suffer in silence as well. And I mentioned this earlier that the brain is the largest sexual organ, and that to treat sexual dysfunction is really just not treating the organ itself. It's really a multimodality approach. So I call it the 7 pillars of sexual vitality. Is that it's all the S's, meaning stress relief or mindfulness, because the brain is a larger sexual organ. If nothing starts in the brain, nothing's gonna start down below the neck. But sleep is important, and so it's a good diet called sustenance, and I recommend the Mediterranean diet. And the senses, meaning mutually pleasurable senses, so focusing on sensation rather than just performance or orgasm or even erection. And social support and communication with the partner is important, and exercise is important, such as sport, high intensity interval exercise, and then have sexual intercourse frequencies is also a treatment modality as well. So this is how I call it my multimodality approach to sexual restoration for men and women, where we really treat from the brain, addressing the emotional side with breathing technique and lifestyle modification, hormone replacement therapy, nerve restoration with PRP, as well as blood vessel restoration. So we rely heavily on PRP, but we also do shockwave therapy. We also do peptides. We also do supplements, and we also inject in Botox as well too. But we also stress heavily on lifestyle modification, just as the 7 S's that I mentioned earlier about diet and exercise and sleep and mind-body connection as well. So it takes a multimodality approach sometimes to just not just treat the sexual organ itself. So I want to end with saying that we're not treating sex, we're just not treating orgasm. We're really, in the end, it's about relationship, it's about love, it's about connection. It's something that is so integral to our well-being and who we are as human beings. So we're really treating something that it's essential to all of us, it's important to all of us, but the patient does not know there is something wrong or there is a treatment available. So I want to thank you for being here and participating in my talk. So if you want a copy of the slides and the female sexual dysfunction questionnaire, scan this QR code. And I will email you the slides and the questionnaire so you have it as a reference, and also a questionnaire if you want to print it out and give it to your patient, and you can use it as a monitoring questionnaire that when they come to visit, whether they're responding to treatment or not. All right, so that is the end of my talk.
Thank you so much, Dr. Truong, for that informative information, and I truly enjoyed, and I learned a lot. And now we have Dr. Christopher Sandra. Dr. Sandra, we all ear, so we're waiting for your insight
Okay.
with the.
I actually have my slides here.
Oh.
Let me just share this real quick and let me know if you can see
Yes,
it.